distinguished guests, ladies and gentlemen, good morning. We feel privileged to welcome you all on behalf of the organizing committee to the Primary Healthcare's 11th Biennial Conference, this year under the title Excellence and Beyond.
This year's conference will focus on the evolution of the primary healthcare and what is planned in the coming future. We can start immediately and leave it to keynote speakers to give us a walkthrough on the exceptional level of developments and coming projects. Wish you all an interesting and fruitful day.
The Honourable Deputy Prime Minister and Minister for Health, Mr. Chris Fearn, couldn't be with us today in person because he had to be abroad. However, he recorded a short message to share with you on this special occasion.
Rodwa tajba. Wieħed mill-pilastri ewlenin tal-politika tal-gvern f'qasam tas-saħħa u li kemm jista' jkun il-kura, is-servizz tas-saħħa nagħtuh viċin iċ-ċittadini tagħna, nagħtuh viċin il-residenti fid-djar tagħhom, fil-bliet u fl-irħula tagħhom, u l-isptarijiet li rridu jkunu ovvjament tal-livell ta' eċċellenza jkunu hemmhekk biss għal dawk il-każijiet li ma jistgħux jieħdu l-kura tagħhom fil-komunità. Għalhekk dawn l-aħħar snin qed nagħmlu enfasi kbira biex naħdmu aktar mat-tobba fil-komunità, mal-ispeċjalisti fil-komunità, ma' dawk il-professjonisti kollha li jagħtu servizz fil-komunità tagħna. Qegħdin niftħu xahar wara ieħor bereġ ġodda ċentri komunitarji tas-saħħa fil-bliet u fl-irħula tagħna u l-pjan tagħna u t-tir tagħna hu illi kollna ċentru tas-saħħa komunitarju ġo kull belt u raħal ġewwa Malta u Għawdex. Ma daw ukoll qegħdin nżidu servizzi fil-kliniċi tagħna, fil-health centers tagħna biex kemm jista' jkun nagħtu aktar servizzi viċin il-poplu tagħna. Mhux biss is-servizzi tradizzjonali li aħna mdorrin naraw fiċ-ċentri tas-saħħa, imma rridu noħorġu anke servizzi li sal-lum jingħataw biss ġewwa Mater Dei kemm jista' jkun ġewwa il-bereċ u l-health centers tagħna. Fosthom, pereżempju, servizz ta' Gpa Clinic li waqt li jibqa' ġewwa Mater Dei jkollu wkoll servizz fil-komunità, servizz ta' saħħa mentali illi llum irridu nintegrawh mal-komplement tas-saħħa tagħna manka nagħtuh mhux biss ġew l-isptarijiet tagħna manka fiċ-ċentri tas-saħħa, kif ukoll numru ta' servizzi mill-ispeċjalisti tagħna illi tradizzjonalment jagħtu s-servizz tagħhom ġew l-Outpatients Department tal-isptar, irridu wkoll kemm jista' jkun dawn is-servizzi intuhom fil-komunità. Apparti dan li tradizzjonalment huwa magħruf bħala l-kura primarja, qegħdin ukoll ninvestu b'mod qawwi biex ikollna wkoll għall-ewwel darba ġewwa pajjiżna il-konċett tal-kura sekondarja, terzjarja l-isptar, primarja dak li diġà semmejna missa ħajkollna żewġ hubs kbar, kalla jrid minn ftit xhur oħra ninawguraw u nibdew nagħtu servizz mill-ħab ċensu Mawran taraħa ġdid, ma wkoll se jkollna hub fin-naħa ta' fuq ta' Malta illi jkun it-triq ta' fin-nofs ta' bejn il-kura li nagħtu fid-djar u fil-bereċ u l-kura li nagħtu fl-isptarijiet. U dawn iż-żewġ ċentri kbar, il-hubs kbar, ħajkunu qegħdin jagħtu din il-kura sekondarja, inkluż pereżempju servizzi ta' ambulanza, daycare surgery, kif ukoll kura dentali f'dawn il-hubs li ħajkollna fiż-żewġ naħat tal-gżira tagħna. Però llum irridu nibdew nħarsu biex immorru lil hinn minn hekk. Mhux biss nagħtu kura lill-pazjenti tagħna fil-komunità, imma nħarsu is-saħħa tal-pazjenti tagħna fil-komunità. Mhux biss nistennew sakemm jimirdu u ntuhom il-kura, imma ntuhom l-għodot u ngħinu u nkunu attivi b'mod proattiv biex kemm jista' jkun ċittadini tagħna ma jimirdux jew idumu ma jimirdu. U allura rridu nżidu ħafna l-isforzi tagħna, l-fokus tagħna, r-riżorsi tagħna, l-enerġija tagħna fuq il-kura preventiva biex nagħtu aktar saħħa liċ-ċittadini tagħna, nedukaw aktar, nuru aktar, mhux biss x'għandha tkun is-saħħa fiżika tal-persuni li jgħixu fil-komunità li jgħixu fil-pajjiż tagħna ma kas-saħħa mentali. U dan tax-xogħol di responsabilità taqa' fuq kull wieħed u waħda minna, speċjalment dawk il-professjonisti li llum diġà jagħtu servizz f'dak li llum insejħulu il-qasam tas-saħħa primarja. Jiena qed nara wkoll u nifhem li matul il-ġurnata tal-lum tkun qed niddiskutu l-isforzi tagħkom tagħna lkoll biex ikollna anka standards li huma għoljin u li huma benchmarked ma' standards internazzjonali, l-ISO certification, din hija xi ħaġa importanti ħafna illi nagħmluha u rridu nagħmluha across the board. Però jiena llum għandi naqra ta' sfida għalikom. Vera illi s-servizz tas-saħħa tagħna huwa maqsum f'setturi differenti, l-kura primarja, l-kura fl-isptarijiet, issa ngħidu l-kura sekondarja, il-kura tas-saħħa mentali. Però l-pazjent huwa wieħed. Għalkemm is-servizzi huma maqsumin biċċiet differenti, il-pazjent huwa wieħed u l-kura li jisħoqlu pazjent għandha tkun waħda, u għandha tkun waħda holistika. U allura l-isfida tiegħi llum għalikom hi li rridu naħdmu flimkien u qed nieħu pjaċir li t-tema tal-konferenza tagħkom illum hija flimkien għall-eċċellenza, flimkien għall-eċċellenza, rridu naħdmu flimkien biex dawn id-diviżjonijiet jista' jkun kultant artifiċjali bejn sezzjonijiet differenti tas-servizz tas-saħħa tagħna inwarbuhom. Ma jistax ikun pereżempju illi jkollna sistema ta' IT b'servizz wieħed illi ma jitkellimx ma' sistema ta' IT f'servizz ieħor, għax il-pazjent ħajmxi minn servizz għal ieħor. Irridu naraw ukoll ir-riżorsi li għandna madwar il-pajjiż ma jkunux limitati biss jew magħluqa biss ġo servizz wieħed, imma rridu nużawhom kemm jista' jkun mill-bidu sal-aħħar biex il-pazjent intuh l-aħjar possibbli. Illum diġà għandna sistema tas-saħħa illi eċċellenti. Grazzi għal ħaddiema tagħna, professjonisti tagħna, għalikom illi qegħdin hawnhekk f'din il-konferenza llum. Intkom l-aqwa riżors illi għandu dal-pajjiż fil-qasam tas-saħħa, ir-riżors uman. Jiena konvint illi flimkien nistgħu ninsow l-egos tagħna imma nħarsu lejn il-pazjent. Aħna nitlu fil-qasam tas-saħħa biex noffru servizz il-pazjent. U allura importanti li da servizz ikun holistiku mill-bidu sal-aħħar. M'għandi ebda dubju illi jekk naħdmu flimkien u hekk ħajġri bix-xogħol li nagħmlu kollha flimkien ħankomplu ntejbu is-servizz diġà eċċellenti illi nagħtu lill-pazjenti tagħna, lill-klijenti tagħna. U ma ninsewx ukoll u rridu nkunu attivi wkoll fiha di. Illi s-saħħa ma tibdix u tispiċċa bis-servizz tas-saħħa, imma dak kollu li jiġri madwarna ħajjaffettwa s-saħħa tagħna u s-saħħa taċ-ċittadini Maltin. U rridu nkunu proattivi fiha di. Rridu nħarsu lejn l-effett li jkollu l-ambjent u l-kwalità tal-arja fuq is-saħħa tagħna. Lejn il-kondizzjonijiet tax-xogħol tal-impjegati li ħajkollhom effett fis-saħħa fiżika u mentali ta' min qiegħed jaħdem. Il-mod ta' l-standard of living ta' kull wieħed waħda minna kif qed jaffettwa l-ħajja tagħna. Da kollu ma nistgħux injaraw, rridu nkunu responsabbli għalih aħna wkoll, rridu nitkellmu f'isem il-pazjent ukoll. Jiena konvint li flimkien ħankomplu ntejbu is-sistema tas-saħħa tagħna, ħankomplu nibnu fuq dak li huwa diġà eċċellenti biex flimkien naraw, niżguraw li jkollna servizz tas-saħħa aħjar, li jkollna saħħa tal-poplu tagħna aħjar, li jkollna ħajja aħjar biex kollha kemm aħna eventwalment ikunu qegħdin ngħixu ġewwa Malta aħjar.
We thank the Honourable Deputy Prime Minister and Minister for Health for his message. We will surely take the challenge. We now invite Ms. Rosanne Camilleri to come on stage and give us an overview of the past 24 months and a sneak peek on the coming projects. Thank you.
That was a bit of a challenge because I'm scared of heights. So, distinguished guests, ladies and gentlemen, colleagues, good morning. It is once again my pleasure and privilege to participate and address the 11th Primary Healthcare Biennial Conference. 4 years ago, as I stepped in to lead the primary healthcare at the behest of the Deputy Prime Minister and Minister for Health, Mr. Chris Fern, my first impressions during my listening tours at the various health centres did manifest that another stimulating adventure within the health domain was about to begin. A cursory look at what has been achieved since then reveals that those expectations and our resolve for a better future are being realized. I shall go through our performance in a few moments. The chosen theme for this year's conference is Excellence and Beyond, a theme which is most fitting and reflects government's resolve and firm standing of providing the very best for the well-being of society. The distinguished keynote speakers, together with a group of primary healthcare professionals, will be illuminating the conference with their most valued presentations. We shall learn in detail on the strategic future of the health services in Malta and the vast number of services that we, our primary healthcare, strive to deliver as part of our holistic, client-centered outreach approach. Almost 75 years ago, the WHO enshrined the Constitution, the maxim that health is a fundamental right for all humanity. Indeed, the right of health has been and is paramount to WHO's identity and mandate. Malta, with its blessing of having a bipartisan accord on the importance of the sector, is a prime example of having excelled in its solidarity with this mantra. The last years were unprecedented. We witnessed the emergence of a silent revolution in the national health services in general, and the last 4 years in primary healthcare in particular. Major refurbishments were carried out at a significant number of community clinics across the Maltese Islands, thereby facilitating the new primary healthcare's outreach of its core services concept. The first 3 centers of excellence, which include the Floriana Primary Eye Screening Center, the Lua Speech and Language Pathology, and that of Birkirkara Podiatry Services, are now in full operation. The fourth, one focusing on diabetes endocrinology, is on its way and will be up and running in the first quarter of 2022. A number of new services were added to further out our outreach initiatives, such as physiotherapy, phlebotomy, and the provision of mental well-being services are just but a few to mention. The engagement of medical consultants to address diabetes and endocrinology, ophthalmology, and cardiology was also an innovative initiative. The introduction of groundbreaking digital infrastructure incorporating the electronic patient record IT system was instrumental for our much-needed quantum leap towards innovative information technology organization solutions. The primary healthcare received the most significant award for this initiative, and months later we were also nominated for the World Summit Award 2021, promoting local digital innovation with high impact on improving society within the framework of the United Nations. We regard these developments as massive achievements. The electronic patient record platform will allow us to scale up our service provision through the introduction of modern and advanced IT technologies that benefit our healthcare professionals and the patient. The system was also the critical medium for the newly set up Primary Healthcare Telemedicine Support Center, situated at the Mosta Technopark. We shall be learning more on this later in the day. Scrolling through the pages of the 11 newsletters that we published in the last 4 years, we will be delivering a pen drive later on for you so that you can see them at your own leisure. One wonders how it was physically possible to accomplish this much in such a relatively short time. But yes, we did it. And we did it in style, having in the main not only timely honored the completion of projects and avoided overruns, but surpassed expectations. Since the theme today is Excellence and Beyond, I am enthusiastic to share with you some of our highlights queued up for the next 5 years, focusing on those scheduled for years 2022 and 2023 as follows. The finalization of the refurbishment and migration of the Gżira Health Centre, the Victoria Health Centre, the Birkirkara Health Centre is going for the phase 2 project, the Birkirkara Health Centre, the Southern and Northern Regional Hubs, the new Tajorni Community Clinic, the new Tarshin Community Clinic, the Marsa Scala Community Clinic, the relocation of the National Screening Center, and the introduction of abdominal, aortic, and aneurysm screening at health centers and community clinics, the introduction of palliative care in the community in line with the National Cancer Plan, weight management and well-being clinics as another center of excellence, expansion of the speech and language pathology services in church schools and private schools, the introduction of AI technology, and many more. On the international front, we have sustained our active role with the WHO and the EU. Ladies and gentlemen, I consider awards as being an essential tool for any organization. In our case, the winning of awards by primary healthcare project an even higher level of commitment. In the course of the last 4 years, primary healthcare secured no less than 7 awards and certifications ranging from the Equality Award during the Worker of the Year Award in 2019, the Best Use of Technology in Business Transformation Award in 2020, the National Supporting Business Award in 2021, the Rising Star Award in 2020, the Best Primary Care in the Community Award in 2020, the reconfirmation of the ISO certification, it's an international certification covering all of the primary healthcare footprint, the reconfirmation of the Equality Award by the National Commission for Promotion of Equality. Furthermore, and on a personal level, securing Entrepreneur of the Year for the Healthcare and the Lifetime Achievement Award in 2020 vindicated our firm commitment to developing essential healthcare in the spirit of social justice accessible to all. As the primary healthcare, which encompasses an impressive cross-section of multidisciplinary healthcare professionals team, totaling 1,500 and more, the awards are a manifestation of a positive synergistic cooperation that is a quintessential ingredient for success, particularly and more explicitly during the course of the last 2 years when primary healthcare was in the forefront of facing the unparalleled experience of the pandemic. More fittingly, the recognition of the primary health by the nation's highest institutions stimulated an even more resilient drive by my team to execute the nationwide COVID-19 vaccination program, which kick-started in January of 2020. This was in collaboration and still is with Mater Dei Hospital. The vaccination program is still ongoing, and we are now giving the COVID booster jab from the community clinics, while the health centers are handling the seasonal influenza vaccination program, which has already exceeded over 90,000 vaccinations. This doesn't mean that we are faultless. In an increasingly interconnected and complex world, we all need to appreciate even each other's so-called cognitive blind spots and work harder to improve them. Needless to highlight that the workforce is the steadfast pillar of any organization and typifies one of those forces that tend to the betterment and uplifting of the country's social fabric. In this framework, my executive and management teams are consequently prepared to face with vigor any negative attitudes, talking less and acting more, with a never say enough mindset, always focused on what we do and drawing on the good advice and experiences of others. We were, and indeed we are, truly in each other's friends, confidants, and mentors. Dear colleagues, during the last 4 years, and more intensively the last 2 years, we had constantly kept focus on our determined resolve to provide first-class services to our esteemed clientele, as we face the considerable national and global challenges brought about primarily by the continued evolvement of the pandemic. Throughout this period, we have together adapted to work exigencies where balancing life and work have become even more fundamental. We have implemented flexible working schedules, created a safer environment, coordinated effective work from home, and secured greater organizational success. Despite the unprecedented challenging times, our morale was at its highest, mutual respect was evident, and the positive attitude reigned supreme. I will surely be voicing the sentiments of the Deputy Prime Minister in stating how proud we are all of you as a united team. On behalf of the Primary Healthcare Senior Management Team, I would like to thank all the workforce for the valued efforts working diligently not only towards making this crisis a learning experience and an opportunity to improve and excel for the benefit of all across the Maltese Islands, but also for your uninterrupted drive to modernize the overall primary healthcare to such an unprecedented level. To coin Aristotle, we are what we repeatedly do. Excellence then is not an act, but it becomes a habit. Please accept my heartfelt gratitude for setting a perfect example of dedication, professionalism, and responsibility. Allow me a few more seconds to express my heartfelt thank you and appreciation to the Primary Healthcare Conference Committee. It's Dorothy, I will call them here. Dorothy Cicluna, Josette Cicluna, Adrian Parch, Deborah Farrugia, Maria Briffa, Alfred Farrugia, Dominica Topardi, Daniel Corso, and Rihanna Villapage, in no particular order, and the supporting teams who have worked incessantly these past weeks to make this day a memorable and pleasing one. I thank you for your attention, and I augur you enjoy what we have prepared for you. Thank you.
Thank you, Ms. Camilleri. That was extremely informative and indeed motivating. We are so honored and privileged to have you as our team leader. Now, I cordially request Mr. George Villa, Head Advisory Grant Thornton, to come up on stage for his presentation, please.
Good morning. I have to continue with the theme. I think it is indeed a privilege to be here, and I think it is only thanks to your collective efforts that we are all here. Thank you so much for all of you and for the excellent work that you've done during the pandemic for the rest of the nation. Thank you so much. The presentation is referring to something that started before the pandemic. This has been coming for quite some time. We had the privilege of supporting primary healthcare in its planning of the holistic reform of the primary healthcare service, as well as supporting in identifying the right funding for the program, as well as on a continuing basis looking at the outcomes that are coming out of this investment. And this presentation is, what it is trying to do is actually giving a very brief summary of what has happened and the first results that we are getting out of the surveys that are ongoing. Unfortunately, they weren't the surveys that we carried out. We had to do much more, but due to the pandemic, we were slightly slowed down, but we will continue with our resolve to make up for the lost time. So in essence, it all started with a report in 2016, which was clearly indicating that the primary healthcare sector had suffered slightly in the past by not getting enough attention. And in 2015, another report had stated that there is very strong workforce development and coordination. However, Malta had scored slightly lower on governance, economic conditions, continuity, comprehensiveness, and accessibility. And this is where the primary healthcare came up with the reform, which, apart from the construction of the North and South Regional Primary Healthcare, as we have already heard about this morning, was also a holistic refurbishment of the health centers and communities clinics around all of Malta and Gozo. But apart from the investment in brick and mortar and the finishing of these places, the reform also looked into the importance of having an information campaign that aims to encourage public primary healthcare utilization, international certification and accreditation, as we have already heard, and the introduction of a scalable information technology infrastructure. So how did we get here? As I have briefly said, through the preparation of a very detailed cost-benefit analysis, we supported primary healthcare in convincing the National Development and Social Fund to award a 10 million grant for the financing of this project. And not only financing the project, also financing the surveys on an ongoing basis to ensure that the outcomes that had been targeted at planning stage are actually going to be achieved. Some of the outcomes that are expected is, for example, and this is following a classification by the World Health Organization when it comes to assessing investments in healthcare. The idea and the plan is to achieve 300,000 patient visits per annum. The cost savings of circa 3.7 million by way of ensuring that people who can get support that they need in primary healthcare do not need to go to Mater Dei. Improved accessibility to persons because of proximity to primary healthcare when compared to Mater Dei. The reduction in socioeconomic inequality, which is extremely important, and we've already heard about it, by making sure that this fundamental right is available to everyone, irrespective of class and economic background. Reduction in waiting times, which is also a key outcome that is expected, and hopefully the avoidance of unnecessary deaths by giving the proper support at primary health level. The monitoring and evaluation will be looking at these 5 different aspects: patient satisfaction, first point of access, awareness of the services that are provided, the level of accessibility, and the service delivery, amongst others. This is a graphic of where the health centers are located. What have we done so far? The patient surveys, we have carried out 5 patient surveys up till now, 1 population survey, and we still have to carry out a staff survey and also look into the administrative records, and that will obviously give us an insight as to whether the key outcomes in terms of managing to attract more people to the primary healthcare, managing to ensure that people who can get serviced at primary healthcare and not at Mater Dei are actually using those services. So this is what we've done till far, up till now. We have done a collection and analysis of the pre- and post-intervention at the Podiatry Center of Excellence in Birkirkara. And we have also done pre-intervention patient surveys at Gżira, Gozo, and Birkirkara. And this will now obviously give us, once we carry out the post-intervention surveys, we will have a yardstick to compare to, and I'm sure that we will see that the outcomes that were hoped for were achieved. Key findings until now, unfortunately, not many, but I'm sure that as soon as we start getting much more coming in, we will have much more. 38% of your current customers, your current patients, are saying that they are satisfied, and 33 are very satisfied. In terms of people coming to primary healthcare, 71% typically, 71% of the population typically come to primary healthcare, and 19% in a year would attend or come to the local community clinic. Familiarity with the community clinic service is unfortunately still not there. So the 49% is higher than the 35 of the respondents who have said that they are aware of these services. And the awareness of the opening hours is also on the very low side, with 62% of people saying that they are not aware of the opening hours. And this is testament to the importance of creating more awareness information campaigns, as indeed you are planning and executing. Quality of service is obviously topmost in priority given by people who would like to use the services of primary healthcare, whereas greater accessibility and continual relationship were the second and third most important things that were mentioned by the respondents. 66% of the respondents said that they would consider the health centers as their potential first point of contact once significant investment in the system is carried out, and there again, this justifies the importance of the reform that is currently being executed. Opening hours of health centers, 30% are moderately aware and 20% are extremely aware. So the rest, there again, more importance given to the information campaigns. Podiatry podiatry is the first one where we have the pre and the post, and there again the indications are very positive, with 64% pre-intervention saying that they were happy with the service, going up to 83%, which is, I think, extremely encouraging. 33% of the respondents were first-time users of podiatry services in 2021, whereas 34% were not first users, they were repeat users, but were in the Birkirkara Podiatry Center of Excellence for the first time in 2021. That's as much as we've done up till now. I hope to have much more to share with you as more surveys come in. And once again, thank you very much for the privilege and the honor to be able to support such an important role that you are fulfilling for the rest of the nation. Thank you so much.
Thank you, Mr. Vella. Now let's have the pleasure to call on stage Ms. Carmen Chantar, Chief Executive Officer, Foundation for Medical Services, to deliver her presentation. Thank you.
Good morning, everyone. I have to start by apologizing for my voice. I'm told that I need to change my batteries, but hardly likely in the middle of a house move and with the work that we have ongoing. I'd like today to share with you some initial thoughts about the Southern and the Northern Hub. Basically, we are at a more advanced stage regarding the Southern Hub. However, I will share with you, obviously, as well, the status in vis-a-vis the Northern Hub as well. So, what we are aiming with these regional hubs is to create pillars of, that will sustain the healthcare services for the future. We all know how difficult it is nowadays to continue increasing the services at Mater Dei, having a lot of restrictions vis-a-vis the space allocation. We do not intend, obviously, to lag behind in terms of new services being offered. So the regional hub, both the one in the south and the north, will offer the opportunity to continue increasing the services that we offer to our population all under one roof. They will both be one-stop shops, basically offering comprehensive healthcare services. And the intention, and we are working very actively towards it, is to be able to raise the bar, not only in terms of services being delivered, the quality of the services being delivered, but also in terms of design and infrastructure. The Chansumouran Regional Hub is now at implementation stage, whilst the Northern Hub is still at design stage. I will give you more information at a later stage regarding both. Where does FMS come in? Basically, FMS is responsible for the project management from inception stage. Basically, we start off with healthcare, with the primary healthcare by discussing their requirements. Eventually, we do the brief of the project itself, and then we continue with the tasks one by one, which involve basically project management, design and architecture, engineering services, which are mechanical, electrical, and nowadays within FMS we also have the skills to be able to do the biomedical side, which in the past we didn't have. And we also offer consultancy in terms of HR and also procurement. What is our role? Basically, we start from the planning stage where we lodge the planning application. We actively work towards getting the permits, obviously. In the process, we do designs, the specs, we do the schematics. Then we start with the cost estimates, tender preparation, and also providing the technical input which will be required at tendering stage. The team always got to continue on with Roseanne's point about achieving excellence. That is something which is going through the different entities within the health department. And at FMS, we also try, obviously, to create buildings which are excellent in nature and which will obviously help the entity after handover to give the optimum service. I shall be focusing now on sustainability because this has been a concept which was not as central to the decision-making and the design process at FMS in the past. However, in the recent years, we have actively worked towards getting sustainable businesses, sustainable developments, sustainable buildings. And doing that, we are making sure that we use environmentally friendly materials and features which eventually will make the building sustainable. What do I mean by sustainable? It has to be a building which makes the best use of water, building materials, energy, and even land. We do give a lot of attention about the land use as well. The objective is to make buildings and design them with using the best practices in the fields at the moment, and in order to increase the benefits in terms of comfort and healthy living and even cost reduction, and reduce the negative impact on the environment as we build and also as we operate a building. What is LEED? LEED is a framework which we use in order to become more sustainable in the planning, design, and also implementation of buildings. It stands for Leadership in Energy and Environment Design, and it is the most widely used accreditation for green buildings. It can be used for any type of building. I mean, the LEED certification is used in offices, is used in retail, is used in homes, but it has obviously an important function when it comes to buildings which are health-related, which obviously already is very expensive to operate, and using the LEED certification would encourage people to consume less energy and also make use of the resources, better use of the resources available. So how do we go about achieving LEED certification? I mean, the LEED certification is not an easy process. It is a lengthy one, and you have to go through the various steps in order to achieve this accreditation. Eventually, Paula Hub will be the first LEED accredited building in Malta, in terms of healthcare, obviously. It will be a milestone for us, and I think that all other developments which are happening nowadays should follow suit. LEED certification will also be achieved for the Northern Hub, for the outpatients building, for the acute psychiatric hospital. These are all projects that FMS is working upon at the moment. So going back to LEED, LEED basically is achieved through the assembly of prerequisites and also credits. And when you obtain credits, you eventually obtain points. Prerequisites are the minimum requirements. Without them, you cannot even be considered. Sorry. For certification, once a prerequisite is achieved, a building may proceed with credit certification. Once credits are achieved, they will contribute towards accumulation of points, which eventually will contribute to the total score. Certification of LEED can be of 4 types, basically. It can be just a certified building, it can be a silver, gold, or a platinum. As I have already mentioned, the Censumauran Regional Hub will be the first development which will be LEED certified in the healthcare settings. It is a development which is happening on the Schreiber ground in Paula. It is co-funded by the European Union Fund 2014-2020, and it will offer a range of services all under one roof. It will incorporate health promotion and prevention services, which is a bit of a move away from the conservative model of treatment, basically, treatment when you're sick, towards a preventative model which will offer care and prevent sickness. This hub will be geared up also to treat minor, yet could be urgent as well, conditions that you do not need to access Mater Dei for the service, and basically reduce the weight on the infrastructure of Mater Dei. This is a video of the works which have happened since June. It's taken from our time-lapse camera, cameras that we use to monitor the works on site remotely as well. Sorry, I don't I can. Some images, as you can see, the work in the past months has progressed a lot, and now the work is showing as well. I mean, during foundation stage, the work is very slow. Obviously, we couldn't meet any other issues, any other problems on site. The site had, we discovered a shelter complex of 31 rooms. Then there was a drainage pipe which wasn't visible to us at planning stage. There was a reservoir, the foundations of the adjacent Schreiber wall. So it took some time until the preparations were made and we could overcome all these obstacles. However, now the work is showing, and it should be that we will eventually meet the timelines that we have agreed upon. At the moment, we are doing structural works on the ground floor, which is basically completed. And also we have ongoing works which are internal and external on level 9. Basically, the vision is that of expansion of the healthcare services, and expansion, we don't only mean that services which come out of Mater Dei are delivered here, but also new services are delivered in these hubs as well. These are artistic impressions, however, they are representing a very factual representation of some clinical areas. I mean, they are so detailed, it includes everything that we have instructed the contractor to deliver in each room. The canteen and the boardroom. The timelines, we are projecting that the project will be finalized in Q3 of 2022, which is next year. And by then, it will be handed over to primary healthcare after the necessary commissioning and handover structures. So we go to the Northern Hub. The Northern Hub is still at a planning stage. The area, however, has been identified. It's a very central area bordering Bujibba and Aura. It belongs to the government, so it's a government site which is currently being transferred to the Ministry for Health. It's a very big site, at 10,000 square meters. The actual footprint of the building will be around 3,600. It will have a massive underground parking. At the current stage, we are planning to have 400 car parking spaces, which is ample enough, more than enough for the healthcare center. However, this allocation of parking might increase because we are currently in discussion with government, and there is the possibility of increasing to relieve a lot of street parking in the area. Obviously, the project will also aim to be LEED certified, very important, and it will cater for a catchment area of about 200,000, which will basically be catering for the population of the northern region, starting from Mosta Bikr Kara Rabat upwards. These services will be offered, the services offered basically will be split in 3 categories. There are services which you will hear more at a later stage, which are already being delivered in the healthcare centers, others which will be introduced in the Paula Hub for the first time, such as the dental clinic, the GU services, and also other services which will be introduced eventually also in the Northern Hub, because obviously from the south to the north, we have also made some reassessment of possible other services which might be required to be introduced in the north. Specialized services that basically we're lacking space at Mater Dei, and taking the opportunity of designing a new hub, we will include them in the Northern Hub. These are a very initial concept of the building of the Northern Hub. Basically, it's an H type of building. There is an atrium in the middle, which will give direction to the patients on both sides of the buildings. The building will be surrounded by a very large landscaped area, as you can see from the artist impression. It will have 2 axes going in and another 2 going out. There will be also a dedicated route for emergency ambulances with car parking, all the services which are required to be delivered from this hub will be catered for. where we are at the moment, we are in constant discussion regarding the layouts. The layouts will be eventually, we're nearing sign-off from primary healthcare, but this is an ongoing process and the discussions continue going until a final brief is signed off. We are also identifying areas which will be dedicated to the engineering plant on the different levels. We have also discussions with the fire consultants. Being a public building, it's extremely important that all the safety measures are catered for. We have done all the ground investigations, that is all complete, topographic, geological, and also toxicity, and that task is ready. Gathering information regarding the services which are going underneath the site. The site is currently partly used as a car parking site at the moment, and there are some squatters, obviously, and that's we are discussing also with the Lands Authority to be able to remove them. Some of them have already been evicted. Only one actually remains unresolved at the moment, so we are nearing the closure of that task as well. But being a site which is surrounded by buildings, we are aware that there are services undergoing the site, both in Malta and water services, but also Go and Melita. So we're in discussion with them to make sure that these services are rerouted at the earliest possible before we start the excavation. Discussions are also ongoing with the planning authority regarding the planning permit. Before we actually put in a permit, we are taking the opportunity to discuss various issues with the stakeholders involved in the planning stage, being ERA, Transport Malta, and also Planning Authority, so that we, as much as possible, make sure that by the time that we lodge the application with Planning Authority, most of the issues would have been thrashed out, rather than doing that task after the planning permit, and then we'll have to do a lot of redesign. In order to save up on hours of design, we try to do the discussions before we actually put in the planning permit, so that we will save up some time. Conclusion, we obviously at FMS try to, as much as possible, take time to plan properly, to make sure that all issues are handled before in their due time. However, we know that it is a very cumbersome process and there is a lot of investment of time and money, but I think that the investment that we are doing, both in terms of resources, financial and otherwise, will help us to deliver 2 regional hubs, which will be unprecedented in Malta. They will offer, obviously, strengthening of the services that we already give in a very efficient way, but this will make it more efficient because, obviously, the environment in which it is delivered is exceptional, and we hope that it will surpass everyone's expectations. Thanks a lot.
We thank you, Ms. Chantar, for your presentation. We can now accommodate on stage the first panel, who will be delivering their presentation in the following order. Dr. Gunter Abela, Developing Primary Healthcare GP Services in the Community. Dr. Patrick Gallia, Handling of the Pandemic. Dr. Sonia Abela, Concepts of Telemedicine.
Good morning, everyone. So my brief today is to very briefly go over the GP services offered by primary healthcare. The focus of our services is twofold: to bring the GP service to the community, to the patient's door, as much as possible, but also to provide specialist service when required. As you know, the GP service currently involves a walk-in service in the health centers and also some special clinics. We have introduced, however, two new initiatives: the Gpa Appointment Clinic and the Telemedicine. The Gpa Appointment Clinic will be dealt with by my colleague, so the telemedicine service will be dealt with by my colleague, so I'd like to speak a bit about the Gpa Appointment Clinics. These clinics provide GPs and clients with the opportunity to have a 15 to 20-minute period whereby the client can discuss a holistic plan with the GP on managing their health, and importantly, to provide the possibility of follow-up with the same 2 or 3 doctors. We also are planning to improve on the already existent diabetes services which we are providing. The proposed care pathway, as you can see, is that on referral, patients with diabetes who have a minor form of the diabetes can be referred to the right-hand side of the screen, to a GP and nurse-led system in the health centers and community clinics. However, if they require further care, they can be referred to the Diabetes Center of Excellence. This is the proposed patient flow, patient pathway for the Diabetes Center of Excellence, whereby we will be offering a one-stop service. The patient will be seen by a number of non-medical healthcare professionals, will be reviewed at the end of their journey through this appointment by a diabetologist, who will then issue an agreed care plan, and which will be given to the patient. We are also considering investing on GP with the concept of GP with special interest. So the concept is that GPs will still be the generalists, it's in their nature, but they will also be able to provide an additional service as regards their chosen specialty. These are the current specialties that we have either in place or in progress, and these are the ones which we are considering for the future. As already mentioned by the DPM, we plan on helping out in the GU clinic delivery by offering a service in the community run by GPs with special interests, with the possibility of referring to the GU clinic at Mater Dei if required. Our future plans also involve enhancing telemedicine services by providing an appointment-based video consultation service, and also providing a long COVID service. I leave you with the slide, which I suppose is self-explanatory, and thank you very much for your attention.
Good morning, everyone. When preparing this presentation, I had the inner gut feeling that things would change in 1 week, and this was the major challenge for us as primary healthcare. Practically, if we look at the 14-day notification test positivity rate by CDMC, we were on the amber zone, but now we're again on the red zone. However, this was the key of our success as primary healthcare, okay? in helping to practically flatten out the curves, okay, when it comes to total death rate in Malta. And also, we had a key role to help in the general vaccination rollout program. In fact, let me present to you some impressive numbers. Over there, you have a list of all the things, all the dynamic set of protocols that we managed to set up over the past years in order to give our major help in the country with the handling of the pandemic. First of all, we set up a COVID-19 follow-up team, which was set up from the start of the pandemic, and also an initial assessment team. And with regards to that, we managed to already to phone on a daily basis to follow directly more than 31,000 patients. Please appreciate the numbers have a plus at the end because things obviously are always on the increase. We also managed to set up the Telemedicine Department, okay, which had a major role in reaching out to the COVID-positive patients in their household. Those under quarantine, they could still access our services 24/7, Monday to Sunday, and also to the general community who basically were afraid to attend health centers in order to practice social distancing. We had a very active key role in the national vaccination rollout program, and here we need to mention not only the COVID-19 vaccination, but also the seasonal influenza vaccination program. As you can see, we have already managed to roll out more than 70,000 influenza vaccines and had in the total 940,000 vaccinations given for COVID-19 alone. Now, another thing that, as a department, we have worked on was to set up a vaccine helpline manned by specialists in family medicine 24/7 for the side effects that come with the vaccination program per se. This provided a 24/7 help to all patients who took the vaccine in order to be able to ask about the side effects and receive medical care and advice about them. There was the setting up of the Allergy Clinic, okay, as well, which basically helped to filter out those patients with histories of anaphylaxis to certain vaccines and other medications in order to guide them to specific clinics to receive the vaccine under constant medical monitoring, further encouraging more patients to take up the vaccination, which otherwise would have not been possible. And over there, we managed to call more than 31, to filter 31,000 patients for these allergy clinics alone. Now, another thing that we managed to set up as well as primary healthcare was the setup of the vulnerability mailbox. Practically, as we all know, we had those vulnerable groups that we needed to reach out to in order to be able to filter them out and give them the vaccine as soon as possible. We managed to pick up 435 who were missed up in the appointment system, those suffering from chronic medical conditions, to pick them up and refer them accordingly. And finally, a small word about the contingency plan. Contingency plan was also drafted, I will show you in the following slides quickly, for all the health centers around the island in order to be able to control the crowding and also to practice safe social distancing. Now, one quick word about the COVID-19 follow-up team and the initial assessment team. And over here, I must mention as Dr. Robert Ellul, Dr. Gloria Policino, and Ms. Pagvella as well for their constant work in being able to set up this system running. As you can see, we had a very efficient patient stratification system set up in order to be able to filter out all patients positive for COVID-19 in order to be able to receive daily telephone consultations, also making use of video conferencing where possible in order to monitor patients in their households, to be able to filter them on their symptoms, their age, their chronic medical conditions, to pick up the red flags practically and to see when to refer. Also keeping in mind their social situation, elderly living on their own, and safety netting as much as possible. We are also proud as telemedicine also to have taken over also the initial assessment team from Mater Dei Hospital, where it's now being run by primary healthcare alone, okay? The initial assessment team picks up all patients who come positive for COVID-19. We phone them, we do the classification for them, we triage them, and we see who needs most follow-up according to their symptoms, etc. Now, and as you can see, those are, that's an idea of the number of referrals we receive on a daily basis. That graph is just showing the dynamic change in numbers that we get on a daily basis. So that's why we need to change our protocols constantly to keep up with the rate. One quick word about the Allergy Clinic and vulnerability mailbox. That was the pathway that was used all throughout the health centers and by doctors at telemedicine filtering patients in order to refer them specifically to the Allergy Clinic to make sure that if there are any adverse reactions to some vaccines, they would be under constant monitoring. Some graphs showing our percentages, and one quick mention about thromboembolic events. Yes, we also managed to set up a separate system to pick up patients with history of thromboembolism in collaboration with the hematology department to be able to filter out these patients to give them advice on which vaccine to take and to be done under monitoring and to be followed up. One last word about the dynamic, the contingency plan that was set up for health centers, drafted by Dr. Abela, who has just presented before me, which was kindly approved by our clinical chair, Dr. Samut, and Mr. Adrian Patch, where patients attending health center attended a system of triage, which proved to be very efficient. One, to filter out patients in the different clinics, filtering the COVID positives, and over here, one last mention of the transport system that we, as primary healthcare, we also managed to set up for those in quarantine or positive for COVID-19, if they needed any of our services from the primary health centers, they would phone us and we would organize that for them to make sure that none of them would be lost to follow up. Thanks.
Good morning. I shall be speaking about concepts of telemedicine, particularly in our local scenario. So by way of definition, if you search in medical literature, we can find a definition that stems from the pediatric field at least 50 years ago, and it is healing at a distance. So this goes to prove that the concept of telemedicine was already up and running, at least in America, in the 1970s. A more recent definition is a service that seeks to improve a patient's health by permitting two-way, real-time interactive communication between the patient and the physician at a distant site. This is also an American definition in 2020 from the American Medicaid services. So I'm just going to give a very brief overview, a background of how telemedicine started in Malta, and it was set up. It was always in the vision plan of primary healthcare for 2020-2021. However, COVID and the pandemic sort of accelerated its introduction and its development. So it was first set up at the Melliha Community Clinic. We had a number of doctors there who were joined by nurses, and we had a small subset of nurses working from the Gżira Health Center. And then in March 2021, we moved to the Technopark, the Mosta Technopark, where we have a very large open plan layout. It also houses the client support system and the call agents and the client support center. And we work hand in hand with these agents as well as with nurses and other allied health professionals. And the fact that it's an open plan layout also helps foster inter- and intradisciplinary communication. It is a subset of telehealth, and This was a cartoon that was doing the rounds recently on social media, and it seems to suggest that doctors are avoiding seeing patients face to face. I think nothing could be further from the truth, at least in primary healthcare. All medical services at health centers continued being offered uninterrupted during the pandemic. And our local telemedicine center is an adjunct, a further move towards excellence, a means to strengthen what is already working and working well. So those are the numbers that we use: 21234, 21231, and 2122244. And patients can reach us 24/7, either by phone or sending photos of any conditions they might have, and also by video conferencing. The latter, video conferencing, is what we wish to strengthen even more because it offers a visual element to our consultations, and there is more safety for the patient as well as for the doctor. However, there seems to be a bit of resistance from the patient side to take this up. So we need to work with other key stakeholders to improve accessibility to all digital platforms in our population at large. All our workstations are equipped for video consultations, and we have constant IT support from our primary healthcare team as well as from MITA. So those are a few of the benefits that are recognized internationally of telemedicine, but are also very evident locally as well. So we have a reduced patient load on health centers. We have no traveling for the patient. He can call from anywhere, anytime. There's no waiting time, so we aim to answer every call in less than 5 minutes. We offer expert gatekeeping and direction, so we direct patients to services, and sometimes they're not even aware of what services are available, so we need to be on top of things and be aware of the constant and dynamic new services that are being offered in primary healthcare. And we offer 24/7 access to expert advice and management. And I want to stop a bit on this and expound a bit because we work very closely. So, like for example, 4 workstations are close together. We would be offering a patient the sort of collected and concerted advice of 4 to 6 doctors at one time. We do ask the patient if he gives us time to consult with our colleagues, and when we have complicated cases, and usually at least in about a third of cases, we do consult with our colleagues, and they will be getting the benefit, of the advice of 4 experienced doctors and nurses, for example, at the cost of a phone call. So this, I think, is a very positive thing to think about. We also had a reduction of home visits carried out by the health center doctors in the first year of 90%, but we have to keep in mind that because of the strict mitigation measures and because we were almost in a lockdown for the first few months, there were less infective diseases, and so in the community, so there was a smaller request for home visits in general. So more recent figures suggest at least a 64% reduction because we do vet them quite strictly. We do work in collaboration with our GPs in the local health centers, and I am currently performing an audit with our internal telemedicine staff, and this has shown over the first 3 weeks of November that we have discussed with and passed on 147 home visits to our fellow colleagues in the health centers, and 144 were carried out. Our clinical decision was not completely supported in only 3 of these cases, which I think is very positive. So what do we do exactly? So as Patrick mentioned before, we have COVID-related performed calls. So these are the calls that our doctors and nurses carry out, not the received calls. And we follow up, both doctors and nurses, all patients that have been risk stratified previously into either medium risk or high risk, patients who are in the community and not hospitalized. And to date, we have followed up at least 28,000 of these patients. Since July 2021, we have taken over also the COVID initial assessment team, and to date we have followed at least 4,300. I think we're reaching now 5,000. And every single patient, so yesterday we had 135 COVID positive cases. So today there are 2 doctors who are calling every single of these 135 positive cases, giving them initial advice and risk stratifying them into low risk where we let the patient call us themselves. We give them the numbers, we give them an information leaflet as well for any red flag signs to look out for. The medium risk patients are called by our nurses. At the moment, we will have 3 nurses working with us, but they are doing a sterling job and really keeping the service afloat. And we have some doctors also following up the high-risk cases. As you can see, it is very resource intensive and it accumulates. So it's a cumulative issue. So when we have 135 cases, we are carrying those 135 cases for the next 14 days until the last of that case is out of quarantine. We also give lab results, and we try and give these by video consultation because as per GDPR protocol. And over the past 18 months, we have received 200,000 medical calls, which I think is quite an impressive figure. These would also include a lot of advice about vaccines and their side effects, about COVID in general. We get a lot of calls regarding mental health, especially at night. Requests for home visits, which as I said before, we do vet. Requests for certain prescriptions and image interpretation. As I said before, our open plan layout helps us perform both intra and interdisciplinary communication to a high degree. And there's a lot of work that goes on behind the scenes as well. So when we say, so for all this to function rather seamlessly, we have to issue standard operating procedures, and these have to be dynamic and updated very frequently. So these would include SOPs for prescriptions, for COVID follow-ups, for the CCIAT, and for home visits, and for issuing of blood results. And we also collaborate very frequently with public health doctors, with health inspectors, infectious disease specialists, pediatricians, and medical and surgical specialists from Waterday. So my last slide is the way forward. So here I'm going to refer to our mission statement, our primary healthcare mission statement, where we want to foster a multidisciplinary team which is committed to excellence, and this is what we're trying to do. So from next week, from our telemedicine center, we are going to have speech-language pathologists working there every day from Monday to Friday. They will be providing autism screening through the Lenti program. We have reached very finalized talks with physiotherapists and podiatrists. They were supposed to start services in around October and November, but they unfortunately had to be shelved when we took over the initial assessment team. We are also very probably going to start offering parent craft services online from telemedicine. So in a way, we are also exploring new avenues to increase patients' accessibility further in our community. And we're thinking also about remote monitoring. What we need to do, I think, also from our side, but also from the general governance side, is we need to advocate with key stakeholders on improving digital access to vulnerable cohorts in our population, such as the elderly or people with different abilities, to continue improving patient accessibility in the community. So to summarize, we want to provide various disciplines under one roof. We want to improve on communication and collaboration. And finally, we want to improve the patient experience. Thank you. These are some resources I refer to.
We thank our panel for the presentation.
Thank you.
Just one last thing before we open the panel for questions. We kindly invite on stage Ms. Ilona Camilleri and Ms. Flair Bugeya to officially launch the second volume of the Primary Healthcare My Health Recipe book. Share with us as well.
Good morning. It is with pleasure that today we will be launching the second edition of my healthy recipe book. We know that eating healthy is fundamental for health and well-being. It helps to reduce the risk of diabetes, high blood pressure, cholesterol, heart disease. And this recipe booklet, which you can find in the in the bag which we gave you today, earlier this morning. It is part of a series, and it was created to complement the dietetics and weight management service which is delivered by the department. The booklet was created with the patient in mind, developed to support individuals who wish to optimize their meals for health. In volume 2, you will find recipes that incorporate nutrient-rich foods. We try to make sure that recipes are quick and easy to prepare with ingredients that are readily available and not too expensive. In this edition, we have included a nutrition information table for each recipe to provide patients with information about the nutrition content of each meal, with values given per 100 grams and per serving. I hope that through the booklet, you yourselves will be inspired to try and experiment with new ideas and new ways of eating, but also that in your practice, you find these booklets useful for your patients to help in supporting health and living well. I would personally like to thank Ms. Camilleri and Mr. Daniel Corso for their support in the creation and publication of the booklets. Thank you.
Good morning, everyone. Thank you for the invitation. Together with Flair, and I congratulate her on the recipe book, the Dietetic and Nutrition Department has this year also recruited 2 new dietitians. Thanks to this, we have our dietary intervention services are being operated not just at 2 health centers, but at 9 different health centers, one of which is the Musculoskeletal Clinic. Thanks to this, we are offering services to several patients with several different health conditions. Apart from this, we are also liaising with other healthcare professionals. Thanks to this, we have started to liaise with the diabetes nurses, as well as with the nurses of the lifestyle clinic. So thank you for this opportunity, because it is also a great opportunity for the patients to have a better service with regards to their health. Thank you very much.
So we now can open the panel for questions, if we have any questions from the audience. I think there are no questions.
No questions? So we can now proceed to coffee break. We urge you to please remain seated, as coffee and rich pastries will be served on your tables. Thank you.
Hope you enjoyed your coffee, and now let's us introduce the next 4 speakers and invite them to come on stage to convey the presentation in the following order. Ms. Marika Podda-Conner, Migrant Health in Malta, a role model for the EU. Ms. Marcon Grima, Nurse-led Clinic, enhancing the role of the nurses. Mr. Carmel Cordina, improving primary healthcare in Gozo. And Ms. Alexandra Azzopardi, the primary healthcare supply chain. Thank you.
Good afternoon, everyone. I would like to thank Ms. Roseanne Camilleri for inviting me to share my work with you, and I would like to thank all the nursing management for the support they give me in my work. So, as a senior practice nurse, I promote cultural competence in primary healthcare. There are several models to do this, which I do not have the time to do this today. However, one thing to keep in mind is to be always culturally aware of your own culture before getting to know other cultures. when we speak about migrants, it's important to know who we are talking about. Are we talking about migrant men or migrant women? Are we talking about children or adults? Are we talking about an individual or a family? Migrants are not a homogeneous group. They are individuals with a particular need and require a culturally responsive healthcare. Social determinants of health, as you know, are very important. Being at the source where the patient resides is very important that you have a better understanding of the living conditions where one is residing and what support he is getting, if any. I have come across women who live in a particular open center, who are pregnant, who deliberately refuse to drink water in the evening, because if they do need to use the restroom at night, they have to cross to the other side of the center in pitch darkness with single men lurking in the area. And would this have an impact on their health? Of course it would. So one question to impose on this issue is, are underrepresented groups surviving or thriving? Of course, people cannot thrive if they are undervalued, if they are discriminated against, or if they are unheard. Intersectionality refers to a collection of elements that may contribute to lack of opportunity or stressors. So you can imagine if being a migrant, you're already at a disadvantage. Imagine if you are a migrant woman with a disability or a part of the LGBT group. Equality and equity are similar concepts. However, equity goes one step forward because it offers a variety of support. Now I will take you on a brief tour of my work. These are health education sessions with migrants, some seminars. The one about awareness and prevention of COVID-19 was taken 2 days before the first case was found in Malta. Human trafficking is usually directed towards unaccompanied children and also women because they are mostly at risk. This booklet was developed for unaccompanied children in order to prevent them from getting into the trap of human trafficking. It is written in very, very simple English, and it can be found on our website. Unfortunately, we have not found a way of translating it yet. These are the recent seminars that were held last November. EU project, we have been involved, primary healthcare has been involved in a number of EU projects. Those of you who have been involved, especially if you've been a project leader, you know what a headache it can be. However, EU projects contribute to capacity building among staff, especially with training. These are some EU projects that we have been involved in. These are the topics of training that we are involved in. This is a session of female genital mutilation with police officers. I'm happy to share with you a success story where we prevented 2 young girls from being taken back to their country to have FGM performed because their extended family supported this practice. With the help of Dr. Sammoud, who expedited his expeditive action together with Dr. Vella Baldacchino, we stopped the girls from being taken out of Malta, and together with a lawyer as well, to have this barbaric procedure. I would like to tell you as well that we are in the process of stopping another 3 girls. Our Cultural Mediators in Healthcare training program, this has been acknowledged by the European Website of Integration, which is part of the EU Commission, and which has been now incorporated into Diploma in Education and Cultural Mediation at the University of Malta. This is now well into the first semester of the diploma. Another service, which is being run by Dr. Marius Caruana, who could not be with us here today, is a clinic within the premises of the detention services where migrants who are within the detention are being seen on the premises, and there are consultants, visiting consultants, who see the migrants on a roster basis. Thank you very much.
First of all, I would like to thank Ms. Rosanne Camilleri for inviting me to speak about the nurse's role. Basically, I'm going to speak about a new concept that has already started in primary healthcare, but now we're giving it more importance as we're expanding it further on into the community. What is a nurse-led clinic? It is run and managed by the nurse. In a nurse-led clinic, the nurse has her own patient caseload. The service involves an increase in the autonomy of the nursing role and empowerment. The nurse-led clinic requires the patient to fit into an appointment, a specific time slot, which requires an appointment system. This is because the nurse requires dedicated time with the patient. The nurse has the ability to accept or admit and discharge patients from the clinic or to refer them to other more appropriate healthcare professionals based on the nurse's own assessment. A nurse clinic, through various studies, show that is an effective alternative model of ambulatory healthcare delivery that uses a holistic framework. What do I mean by this? It means that it's more holistic in the sense of focusing more on the preventive, promotion, and education rather than on the therapeutic and medical aspect. Why develop a nurse-led clinic? There are benefits. It's two-way, both for the patient and both for the nurse. Improved patient outcomes and patient satisfaction. All patients studied during literature review showed that improvement after nurse consultation was very evident, especially it was more evident regarding wound care and clinics in the community. An enhanced nurse-patient relationship, because here communication skills and interpersonal skills allow the nurse to communicate more with the patient and build a relationship. There is increased patient access to appropriate healthcare professionals because there is a collaborative, although this is a nurse-led clinic, these are nurse-led clinics, there is collaboration with the multidisciplinary team and the doctors. An educative role and psychological support. There is monitoring of the patient's condition, especially when one attends these nurse-led clinics in between appointments with the consultant, such as monitoring of blood pressure, monitoring of the blood glucose, etc. Empowerment of the patient, because the patient expresses himself with the nurse and can gain control and motivate himself more for self-care and self-management of the condition or disorder that he has. And a very important aspect which motivates the nurses is to utilize the nursing skills and competencies better in primary health care. We have a lot of nurses undergoing master's degrees and further postgraduate courses in specific areas, which it's a pity if we don't utilize these nurses where they can put more their input for the benefit of the patient. And also, studies shows that besides the patient satisfaction, scores were high also in nurses' satisfaction. Examples of nurse, and I may say also midwifery-led clinics that we presently have are the National Immunization Service, which has been long-standing, the wound management clinics, the chronic kidney disease prevention clinic, the ophthalmic services, which has been not long ago that we have recently launched it as Center of Excellence in the eye screening. We have the Porta Kit service, the Well Baby Clinic. The 18-monthers are checked and assessed by the nurses. And we have midwifery-led services, the Maternal Health Assessment Clinic, and the Parent and Baby Primary Healthcare Support Clinic. This is very useful, and it is also done through telephone because it helps mothers that have just delivered babies and their concerns about the babies and themselves, which just with a phone call, they might get advice. And we have recently, we are expanding and working a lot on the nurse-led well-being assessment clinic in the community clinics. Till now, we have 17 of these, and I am going to explain the process which is needed to have an effective nurse-led clinic. It just doesn't happen overnight. It involves preparation, and mostly it involves professional development and training. Without the proper training in the specific area and professional development, there won't be an effective nurse-led clinic. First, you have to define the aims and objectives of the service. You have to clarify what services are going to be delivered, establish the patient criteria, what patients are going to be seen in this clinic, and training involves a lot, especially recently with the tool for the well-being assessment clinic was developed. It was refined many times and developed and also uploaded in the electronic patient's record, and training was given even on this. Identification of the training needs, links with health science faculty, and I thank the health science faculty because it provided a course for these nurses on self-care management of chronic diseases. Involvement of the practice nurses and the senior practice nurses we have, they gave their input a lot. Training on self-management and self-care, as I mentioned earlier, and enhancement of communication skills, because these nurses who are interested in these clinics must have excellent interpersonal skills. Information of available support and screening services, even outside our entity. It's not only in our entity, and also support services. Gaining support from the multidisciplinary team, and I just recently received an email where there is going to be a committee specifically with the multidisciplinary team, made up of multidisciplinary team, to discuss these nurse-led clinics. And mentorship from liaison nurse and colleagues. I thank all the nurses of the community clinics that served as mentors to their colleagues, because until we are certain that a nurse can work alone, we don't leave her to lead this clinic. Several training and several body systems were made so that this nurse-led clinic would come into effect. And facilitation on ongoing improvement through audits. Obviously, there is always room for improvement, and we always improve where there can be what is working, when we see what is working and what is not working. I'm going to do an example. For example, this is the nurse-led assessment of well-being clinic. The main aim is to provide a holistic assessment of the client. The service aids in empowering the client to a healthier lifestyle through health promotion and disease prevention. The scope of this clinic is to identify the risk factors which are conducive to ill health, identify undiagnosed existing health issues, the opportunity for health promotion and disease prevention intervention, provide access to an integrated multidisciplinary primary healthcare team for better continuity of care. All of these, because we speak, the definition of primary healthcare has been defined and redefined, but all concepts leave the issue that it has to start from disease prevention and health promotion. Referrals for screening, dietitian, there were very referrals for the dietitians, for the elderly help, for the women's health, mental health services. All these were referred from these well-being clinics. I end with some statistics, but the reason that was till October, and we started this clinic, the well-being clinics, in July. But yesterday I just received the total that we have till now, that 3,587 attended these well-being clinics this year, only from July till November. I thank you for your attention. However, our vision, and especially my vision as Chief Nursing Manager, will definitely be to empower nurses and enhancing the nurses' role and introduce more nurse-led clinics. And I hope that such clinics would be also regarding diabetes and other clinics that may be adjunct to the consultant and adjunct to the GP clinics. I thank you for your attention.
I would like to thank Ms. Roseanne Camilleri for inviting me to this seminar, and we are going to discuss or speak about improving primary healthcare in Gozo, the way forward. Gozo has a catchment area normally of about 30,000 people, but it increases during summer, mostly it doubles, and even in winters and certain long weekends. We are preparing in preparedness of migration to the new health center and expanded services. Primary healthcare in Gozo is given and consists of a health center at Victoria and 10 peripheral clinics. The present Old Victoria Health Center was opened in the early 90s and gives services 7 days a week, during the days only, till 8 in the evening. During these last 30 years, there was a steady increase in the demand of services and improvement in the quality of services given, thus creating more demand. The premises of the Old Victoria Health Center, which forms part of the Victoria Hospital, of the old hospital, is very limited, is overcrowded, with patients and staff, and equipment and furnishings are old-fashioned. So the need for a new central premises led to the selection, and the decision was taken, of a central property located between the bus terminus and St. Francis Square, where the Ministry of Gozo is located. which has ample parking spaces. It overlooks the main car park and has easy access to commuters coming from the buses. It consists of 2 floors, the ground floor and first floor. On the ground floor, we will have 2 treatment rooms and 3 GP rooms, and also the doctor's quarters. The first floor consists of the clinics, the NIS clinic, a new mental health care clinic, a new diabetes clinic, and an anticoagulant clinic. These are all on the first floor. Also accessible from outside with already built stairs, public stairs, and from the inside with a lift that takes stretchers. The premises will have several toilets, all accessible by wheelchairs, and even showers for the use of staff, especially in these times of a pandemic. Certain areas will be equipped with a special air condition known as negative pressure in case of communicable diseases, and an automatic standby generator will be in place. In fact, it is already in place. All infrastructure will be new, and only high-quality resources is being used. All medical equipment will be the latest. As a total area, it is roughly the triple of the already old Victoria Health Centre. The migration will take place around February, and staff will be orientated for several days in the new premises. The new services planned on opening the new Victoria. The health center will be open 24/7. That means even night duties, 24/7 GP and treatment room. There will be diabetic clinic, ACC, podiatry, and mental health clinic. All staff at the Gozo Primary Healthcare Center is looking forward for the official opening of the new Victoria Health Center, and staff working in this new state-of-the-art environment will be more motivated to render an excellent service and beyond. Thanks for your attention.
Good afternoon, everyone. I would like to start off by thanking the PHC senior management team for inviting me to present the reform program of the Central Stores. Is it truly my honor? In February 2018, I was approached and introduced to the concept behind supply and logistics management. Following my transfer from the Floriana Pharmacy, together with the PHC Supply Chain and Logistic Management, we started off this journey by visiting the health centers that fall under the umbrella of the primary healthcare. This included visits to all the PHC storage areas where the stock of medical devices and consumables were being stored. It was evidently clear that the system was not in order, with no electronic or manual system available to monitor and control stock usage and balances. Bin cards were not in use either. This meant that the approach towards stock reordering and replenishment levels was based on habit and conception by the charge nurse in health centers. Stock takes and balances were not available either. The situation was untenable, and the decision regarding these solutions had to be taken quickly. the primary healthcare had to introduce a system which is transparent, can be accounted for, and is audit trailable. Following these three main criteria, a holistic supply chain and logistics management system was introduced. The system is currently manually managed. However, preparations are underway for the system to be transferred onto an electronic platform environment. As an officer responsible for the day-to-day running of the store's operation, under the supervision of the management of the entire supply chain operation, I am proud to say that I form part of this challenging initiation and new concept. Today, the entire primary healthcare stockholding system is based on minimum and maximum stock level thresholds and runs on a top-up system depending on each center's turnover. The overall aim behind this supply chain system was to do away with the amateur guesswork way of doing things and instead introduce reliable cost effectiveness and efficient methodologies that allow sustainable stock inventory management, timely distribution, and minimize on wastages. Apart from the initiation of the previously mentioned processes, a central storage area to house all the stock in one location was identified in May 2018. Dedicated stock rooms were also set up into each health center, and in-house training was provided to new store officers to ensure a smooth transition and alignment with the new system. This move was necessary to keep stock holding to a minimum level and to achieve monitoring and control of stock of these peripheral stores. The beginning was obviously difficult, with only 2 stores and distribution officers working on the task. I am now proud to say that currently this number stands at 16 stores and distribution officers, all focused to continually improve the aforementioned process. In July 2019, temperature-controlled transportation for PHC pharmaceuticals, vaccines, medical devices, consumables to health centers, and blood samples and other laboratory samples to MDH pathology was introduced. This new approach has been paramount in ensuring that the cold chain is sustained within primary healthcare and during the collection and transportation of venipuncture and laboratory samples to primary healthcare clinics to pathology MDH. Besides the daily stock preparation and routine weekly scheduled deliveries to all health centers, 2020 brought greater challenges to the primary healthcare center stores. In 2020, we were also tasked with the daily distribution of the seasonal influenza vaccines, as well as the daily preparation of consumables that went into the purposely set up vaccination consumable bags. This dictated a huge logistical coordination exercise so that the seasonal influenza vaccines and their consumables could reach their destination in time, so that the National Influenza Vaccination Program could continue without glitches throughout the health centers and the community clinics spread across Malta and Gozo. The COVID-19 pandemic brought about many new and unforeseen challenges and tasks which had to be quickly added onto all the previously mentioned deliverables. From the start of the outbreak, the stores have played a very important role in providing enough PPEs and other infection control items for primary healthcare to ensure that all our healthcare workers are protected in line with infection control guidelines. The daily pandemic-related urgent orders were timely sent to all health centers to ensure that our operations keep on going. The central stores was also involved with the transportation of the COVID-19 vaccines, and together with consumables for the red bags, these were transported and distributed between health centers and community clinics around Malta and Gozo, a tight time-barred schedule in view of the shelf life of the vaccines. In a nutshell, today, the primary healthcare central stores is proud of what we have managed to achieve in such a short time frame, That is, a professional supply chain inventory setup that adds value to the primary healthcare's operational performance and quality output, while it facilitates transparency and accountability at all times. Last but not least, I would like to end this presentation by thanking Mr. Dominic Azzopardi for being our backbone and mentor throughout this whole venture. His continuous support and help during these challenging times encouraged and empowered us to grow professionally, as we look forward with eagerness for a challenging future. Thank you for your attention.
Thank you, Ms. Padaconnor, Ms. Grima, Mr. Cordina, and Ms. Azzopardi for the informative and interesting presentations. We are now calling a new panel. Therefore, we kindly ask you to return to your tables, please. Let us welcome on stage our next panel, who will be delivering their presentations as follows. Dr. Renzo Paceascia, Electronic Patient Record System. Mr. Ronald Barbara, Innovative IT Solutions for Business Transformation. Dr. Adrian Attard-Trevisan, GPI Group, the healthcare partner. Ms. Lina Sultano, expanding the National Screening Program.
Thank you, Ms. Camilleri, for the invite. And I think we have started a very good voyage of introducing EPR back in 2019. These statistics really prove the amount of work that has gone on with having 100% coverage across all our 10 health centers, as well as the 64 community clinics. Around 1.6 million visits already in our EPR system. 750,000 calls to date. Over 200,000 going to our doctors in the telemedicine center, and room for much development. In the journey, we started with a 100% paper-based system of having the traditional medical files. This involved a highly motivated business transformation, and we are slowly arriving towards a 0% paper-based solution. In fact, November 2019 was our first rollout of the system at Kirkop Health Center, the smallest. And then we continued in the following 6 months to have all the health centers up and running with the system. We had some delays towards February and March because of the COVID situation. But looking positively at this, we emerged with the telemedicine center, which has now proved to be a very valuable asset, which will be continuing for all the forthcoming years. 2021, we've launched in all the community clinics as well. I see the benefits of EPR being many, but can be summarized more crucial of our efficiency, of having all the required information available. Accessibility, patient safety, continuity of care go together, by having all our professionals having all the information necessary wherever they have clinics available and have nothing to do with catchment areas. Security is of paramount importance, and only those professionals who are giving patient care have access to their part of the EPR. And green, I consider it as a good contribute because we're decreasing the number of papers, number of files, no need for transportation, and therefore that assists us to be environmentally friendly. Sometimes I think I am a bit biased in the sense think very highly of EPR. But this has been proven by other panels outside the jurisdiction of the health department, and we have been awarded different awards, naming the e-business awards for best use of technology in business transformation. This was in December of last year. We also came as a runner-up in the National Supporting Business Award. And lately, we have also been accepted to actually represent Malta in the World Summit Awards. So, in a different feeling, different scenarios, different panels have seen that the electronic patient record system has really transformed our business processes and is a valuable asset. I'll stop for a while in this presentation and give you the EPR and what it really means to us.
The Primary Healthcare's Electronic Patient Record EPR IT system is an innovative project, an overnight quantum leap that took off in November 2019, with a transformation from manual paper-based to electronic format patients' health records. This system is a web-based solution which was tailor-made to meet our unique requirements and which seamlessly exchanges information with other systems, thereby fully achieving a patient-centric approach. The EPR allows real-time access to all our multidisciplinary healthcare professionals stationed throughout the primary healthcare's 10 health centers and 56 community clinics spread across Malta and Gozo. The solution also allows secure remote access to the patient's healthcare records. Indeed, the over 1.6 million patients visiting the primary healthcare annually are now benefiting from real-time electronic patient medical history, eliminating the need for paper patient files that were previously occupying important space. This system allows the doctors to issue new prescriptions and to renew previous prescriptions. Prescriptions may either be printed or sent directly to the pharmacist. One other important feature is the booking of investigational tests, including radiology and laboratory tests. Recording the vital signs of the patient is an easy process. The EPR system also fast-tracked the introduction of a 24/7 telemedicine service to remotely consult patients over the telephone or video conference and record their findings. It was also key to address the COVID-positive patients' medical requirements in the community. The system provides our doctors and other healthcare professionals with up-to-date information on COVID-19 positive patients staying at home, while they communicate and monitor them routinely.
And therefore, the success factors. I think the first is by having excellent leadership. And this goes without saying, obviously giving clear direction and the way forward. We also thank GPI Group and their Maltese subsidiary, Umana Medical. Other third parties, Mater Dei Hospital and META, important collaborators for having a successful outcome. Our primary healthcare IT and the GPI support teams, together with the application specialist. And finally, last but definitely not least, we all together, forming one excellent team. Like I say, we can and we achieve. The future, obviously, we are striving very hard to get the fully integrated EPR with CPAS, CTOR, ICM. Very importantly, I think we're moving very close, but we need one final push to get there. And then we have other possible considerations, for example, like telemonitoring. And we could also consider voice recognition software, as well as other inventions that will help us assist in the future history taking and recording of treatments, of encounters. And finally, I leave you with the motto and the challenge that the Minister has left in our plates, but we can and we achieve. Thank you.
I would like to thank Ms. Camilleri for giving me this opportunity today in presenting this short presentation. And I also would like to thank my director, Ms. Isabella Aquilina, for giving me the delegation and delegating me this project, which I'm going to talk about. I'm going to talk about SLOT-TIL. Let's see what is SLOT-TIL. Why this is important? This is important, like the speaker before me has said, we're going through IT innovation. And it's not only IT innovation in our business transformation, but it is also important for our work, the daily work that we do. The buzzword is we need to go into digitalization. That means we're changing from the manual with papers, files, pen and biro into the IT system. How this all started. This is a system, SLOT-TIL. It's about a manpower management within the nursing administration. 2 years ago, we started with the idea of ISO. So the idea of standardization was very, very important. During the process of the ISO, we have found out that many of our daily processes, management processes, they need to be more standardized. So from the system of monitoring our management, nursing management, which requires especially the leave of every employee, the databases of all our employees, we started with biros, calculators, files, highlighting. The idea is that we go into a digital system. So we have created this SLOT-TIL. The aim of the SLOT-TIL is to be launched next year, this year coming, 2022. It is already live on the P drive. We just need to collate the data of this year so we can head start and we start launching it this January. This is important because it goes beyond 2022. This is our future. It is a simple project, but it will give us a lead that we can go through most of our processes into the digitalization. So what is SLOT-TIL? This is a new buzzword. It's already being used by many of us. SLOT-TIL is a collocation of words. SL is sick leave, OT is overtime, TIL is time in lieu. It is three words that most of the nursing administration use during their management of their manpower. What does it cover? This will cover a system, an IT system, on a simple tool that we have, all of us we have in our IT system, that it will complete all the common records of all of our employees, from the vacational leave, all type of vacational leave. We have special leave, unpaid leave, paid leave, banking system, to our sickness record also, the time in lieu, and even the change of shifts that we usually bound everybody needs to do. What is benefits and the goals of this system? This will enable us to provide a better control and improve timely access, and the most important, transparency between all levels of our management, from the floor management to the senior management to the top management. Also, since it is based on an Excel, it is not just numbers, putting numbers, and from numbers you will get other numbers, but it is also a system where we can have a good centralized database system of all our employees, with regards to grades, legends, rota, you name it. Whatever you want, you can find it here, under just one click of the computer. The system is, as I said, it's an updated database system of all our employees, and also it will require also an easy link between different departments. In fact, for me, together with everybody, to come to finalize this project, we had to work together. We started from every level. Thank you for all the charge nurses. They gave us all the inputs that they have, what they need, how they are working today, where they want to arrive. Would like to thank the HR department, because most of the records, all the system, they are at the HR department. And not least, I would like to thank the IT. Without the IT department, we could have never reached to this point today. This system will cover all our health centers, all our entities and services. Our aim is, just like what we've heard today, more projects are coming, more departments are going to open, so this system needs then also to be updated to every unity and entity that we're going to follow. This will facilitate a link network, as I said, and it's going to be a transparent shared management data of leave record, sickness and absences, and even about overtime. It will link with our daily attendance sheets, and it is networked between the floor management, top management, and the HR. With this, we can have a better management of how we are utilizing our people, and our people are the best resources, and sometimes they are the most expensive resources. And with this data, we can also have, on a management level, access to data, so we can have reports on where we're going and where we want to go. The data access authorization needs to be secured with data protection acts, and it is meant to be, it is built up that everybody will have access only to his pertained services he is given. In shortcoming, if, let's say, Birkir Kara Health Center, the management of Birkir Kara Health Center will manage their management and their team. Then the senior nursing staff will, the nursing staff will, of Birkir Kara will know exactly everything, what's happening, and everything will be built up on that one. This is just a snapshot of how the system is. It is built up as a workbook, and in every workbook there will be a worksheet of every employee. I would like to thank you, and I believe what Helen Keller says here, alone we can do so little, but remember, together we can do so much. Thank you very much.
Thank you very much for having me, and thanks for the invite. Hi, my name is Adrian Trevisan. I'm representing here the GPI group. So I wanted to start off by introducing a little bit GPI. What is GPI and what the group does? GPI has been around for about 30 years. It has a long experience in developing long-lasting infrastructures, especially working within the health industry and doing software technologies and services. And in fact, in Malta, GPI has over the past years worked alongside the primary healthcare, as Dr. Pachasha was saying, into the development of the EPR system. However, GPI has been doing this for a very long time, present in over 60 countries and exponentially growing. So GPI is present in over 60 countries. Just in Italy has over 50 offices, operating to 7 international companies, and always working mainly within the healthcare industry and the healthcare and social industry. So GPI is split into 5 different areas, mainly covering software, care, automation, ICT, and payments. Always within this area, GPI has developed a number of international projects spanning across a number of different countries. When we start off from software, GPI has been very present in projects when it comes to health administration, clinical systems, continuing care, projects like the EPR here in Malta, and the list goes on several of these projects. I want to be very short, so I'm not going into delve into the details of these projects, but basically the expertise that GPI brings over is extremely care. When it goes to the care industry especially, and taking, for example, the example of Italy, about 48% of the Italian citizens, when they get through to a hospital, etc., they usually use a service of GPI, of the group GPI. Has also been, so the services, especially in Italy and in other countries, are well expensive. But when it comes to GPI in Malta has recently, in 2020, invested heavily and is continuing to invest. Last in 2020, GPI has acquired, in fact, Umana Medical, a Maltese company specialized in medical technologies, and basically has been growing organically by employing more and more people in order to have people on the ground. In fact, a lot of the R&D also within the group, we have a number of R&D projects which are basically done and developed by Maltese personnel. We're currently just locally about 40 people, but this will be expanded exponentially over the coming year in order for us to continue to grow. We operate from a base in Malta, and this actually is becoming more and more serviced around. So basically, I wanted to actually make this very short introduction in order for us to explain to you what GPI is and the commitment that the group has in Malta that is continuing to grow over time. Thanks a lot for having me.
Good afternoon, and thank you for this opportunity. During this presentation, I will give a brief overview of the 3 screening programs and the future of the service provided by the National Screening Center. In 2018, so the first program of breast screening. Since then, we have done around 240,000 mammograms. This is just 10,000 shy of 250,000 mammograms. Around 14,300 women were recalled for further tests, and from these, approximately 1,500 breast cancers were detected. Currently, we are inviting women between the ages of 50 and 69 every 2 years. In March 2020, the center closed its doors due to COVID-19, and screening was temporarily suspended. Upon resuming screening way back in July the same year, we had to figure out how we were going to catch up on the backlog. This is being done by increasing more daily appointments. 2013 saw the birth of colorectal screening. Since its start, approximately 132,000 fit tests were done. A total of 5,500 colonoscopies were performed, either at Mater Dei Hospital or Gozo General Hospital. Besides hundreds of clients who required polyp resection, thus lowering their risk for bowel cancer, 225 colorectal cancers were detected. Just like breast screening, the colorectal screening was suspended and resumed during the summer of 2020. To compensate, extra initiative colonoscopy sessions were and are being held till the end of this year at either MDH or at Gozo General Hospital. Currently, we are inviting people between the ages of 55 and 72 every 2 years. Cervical cancer screening, the third program, was initiated in 2015. Since then, almost 14,000 smear tests were carried out, and around 530 women needed further testing, that is by colposcopies, and 30 were found to have precancerous lesions, and 7 cervical cancers were detected. Following the end of last year, besides the morning screening appointments, an additional 50 afternoon slots were added every week. This was done to catch up on the backlog and accommodate women who work. Currently, we are inviting women between the ages of 25 and 41. COVID-19 has hit us hard, just like any department. For some, screening might not be deemed as important or necessary since we are screening the healthy asymptomatic population. But as you can see from this presentation, we do find early precancerous lesions and detect early cancerous growths. It is the foundation of screening to decrease the incidence and mortality rate from cancer. As one can note from several adverts, especially of Listerina, cancer can cost thousands of euros to individuals, not to mention to the state. So I ask, why do we need to take screening seriously? According to the Maltese Cancer Registry, the incidence of breast and bowel cancer are the 2 most common cancers, while mortality rate, they are the 2nd and the 3rd cancers, followed by lung cancer. We cannot ignore these facts. Several papers note that COVID-19 has greatly affected population-based screening, and all agree there is little or no doubt that this will lead to more cancer deaths in the future. On a positive note, regarding cervical cancer, according to the European statistics, the Maltese Islands are at the very top with the least incidence and mortality rate. I prefer to think that maybe because I lead this screening. But joking apart, we must agree that our health services are indeed working. The National Screening Centre will continue to strive to add more screening opportunities, and if it is possible, continue to expand the screening age. We will also continue to promote awareness on the importance of screening and detecting precancerous or early cancer growths. Given the opportunity, we might also consider other new screening programs, that is both cancer and non-cancerous screening. This is just us being very positive. On behalf of the Screening Center, I would like to thank the primary healthcare management, especially Ms. Camilleri, and for giving us this opportunity to share with you our success. Thank you.
Thank you, Dr. Pacheasha, Mr. Barbara, Dr. Attar Trevison, and Ms. Sultana, and well done for the informative presentation. We are now calling our last panel, who will be delivering their presentation in the following order. Mr. Rosario Mizzi, Speech and Language Pathology in the Primary Healthcare. Ms. Jacqueline Shiberas, Shaping Physiotherapy in the Primary Healthcare. Mr. Andrew Shikluna, The Impact of the Center of Excellence, Podiatry Services. And Mr. Ivan Farrugia, Podopediatrics at the Center of Excellence. Thank you.
Thank you for giving us this opportunity to share the experience of the speech-language pathology services with all of you. SLPs have been committed to provide community services since the very start, since 1981. SLP services within the public services is provided across 4 ministries. Obviously, the vast majority within the Ministry for Health. We are providing a service to all ages, practically. We say from the cradle to the grave. And our population is 60% pediatric clients and 40% adults. Across services, we provide 60,000 sessions a year, 50% of which are all based within primary healthcare services. SLP services, in fact, are present in 9 health centers, 26 community clinics, 31 government schools and 1 church schools, 28 elderly homes, and 2 resource centers. This provides a very good coverage across Malta and Gozo, making our services easily accessible to the public. Since February 2018, SLP services were ISO certified, and in July 2018, the Speech Language Center was inaugurated as a Center of Excellence. All services are focused and based on a client-centered philosophy, a service which starts in the clinic and goes beyond according to the client's needs. Services starts in the clinic through individual or group sessions and specialized intervention programs. Further to this, the speech-language pathologist provides also support to the next of kin, as the communication partner is an essential stakeholder. We don't communicate alone, but we communicate with others. We also support and liaise with other professionals and stakeholders, as speech, language, and swallowing are linked with other life functions and developmental processes, especially social, literacy, and education processes. The SLP also provides services in the client's homes, schools, occasionally places of work, and also leisure, as to ensure better generalization of the skills from the clinic to beyond. Our pathway to new practice opportunity is paved by the following principles. Important guidelines and parameters are provided by ISO certified practices, designed by policies and SOPs. To ensure customer-centered services, we are also guided by customer feedback through the Customer Satisfaction Survey. This ensures the continuous molding of SLP services which better matches the client's needs. The full process is continuously reviewed and measured through key performance indicators and outcomes, internal clinical audits, senior peer support, and an open communication policy. This ensures better team dynamics and building stronger bridges between teams and entities. This is intended to lead to better continuation of care and a more holistic approach to client care. Another important stone in this pathway is continuous professional development and growth. We cannot aspire for better services if the staff do not upgrade both their clinical and professional skills in client management, support, and care. This pathway keeps us in line with the strategy of the Directorate Allied Health for all allied health services, based on 3 pillars: quality management, outreach to our customers, and continuous professional growth, and is also in line with international speech and language pathology standards. From the present to the future, based on 3 levels, we look forward to expand our service accessibility. Hence, we look forward to be closer to the client by further expanding to new community clinics and also more government mainstream schools. We look forward to expand this year's pilot project in church schools, and we are already discussing the possibility of moving on to more church schools. We will also eventually explore the possibility to expand our service in private schools at a later stage. We really look forward to provide more specialized services and specialized clinics, especially through the opportunity of the new Paula and North hubs. On the level of service delivery, we need to continue to build on our clinical resources, which are better tailor-made to our culture and, above all, our unique language. We already built 2 assessment protocols, one for language expression and another for language comprehension. In the pipeline, we have 2 projects, one based for literacy assessment and the other one for aphasia difficulties. We need to evolve towards more online documentation and better use of EPR and reduce paper documentation. We need to grow in our clinical skills and personal skills through CPD, so our performance is always up to standard. We need also to build stronger teams within the entities and also across entities. We cannot work in silos, especially in our field, where we need to communicate in all the client's experience. On top, we need to grow at the level of customer feedback. All our expansions need to take into consideration our customers' needs. The customer needs to remain the most important stakeholder in our service delivery. Our satisfaction, in fact, this year, although all the negative impacts of the pandemic, 99.9% of our clients stated that they would recommend our SLP services to their family and friends. We look forward to continue building on this achievement. I thank all my colleagues who all together we form a very proactive and dynamic team. And thank you all for listening to my presentation. Thank you.
Thank you for giving me the opportunity to share with you some development in physiotherapy services in primary healthcare these past 2 years. Mainly community clinics, excuse me, and self-referral. So, in 2019, October 2019, we were given the first opportunity to open our services in community clinics. This started in Zaytoun Community Clinic, and prior to this, we had only been delivering our services from health centers. We have since expanded in 10 clinics, and these are Gura, Marsa Shlogudia, Kalkara Asha, Santa Lucia, Melliha, Attard, and Zuri. Two of these clinics, mainly, which are Melliha and Marsa Shlok, being the furthest north and south, we have equipped fully, just like other health centers. And this makes our service more accessible to our clients who reside in the areas and the surrounding areas. In community clinics, patients are assessed, treated, and advised on self-management. And should the condition require other modalities other than rehab and manual therapy, then they are referred to the main health center to be seen more often than not by the same physiotherapist for continuation of treatment. The frequency of session depends on, at the community clinics, varies, all right? And this depends on the population of the locality and therefore the demand, thus ensuring a sustainable service. Our future plans, direction for community clinic is to continue offering our services in other localities where there is a demand and invest in other rehab and electrotherapy and human resources. With the opening of community clinics, physiotherapy services introduce a new concept for the public service in Malta, that of self-referral or direct access. This was first introduced in the community clinics and has now been extended to all the health centers. This is a poster which we have made, which we'll be distributing to all health centers and community clinics in order to inform the public of this new service. So what is direct access or self-referral? Self-explanatory. It is the ability of a client to refer himself or herself for physiotherapy treatment without needing the referral of a doctor or a GP or consultant. Traditionally, physiotherapists have always needed the referral of a GP or consultant to assess and treat a patient in the public sector. As of this year, all physiotherapists within the primary health have been given the go-ahead to be able to accept patients without a referral. This was a huge milestone for our profession. So who is eligible to self-refer for physiotherapy treatment? So adults, 16 years and over, suffering from musculoskeletal conditions, sprains, strains, neck pain, back pains, people who have fractures and post-removal of fractures, non-acute post-op conditions, example replacements or orthopedic surgeries. We do not see neurological conditions, no women and men's health, or pediatrics. These are all referred to the appropriate clinics. So prior to be given an appointment, our receptionists, who were trained before, ask some pertinent questions to make sure that these are eligible for self-referral. They are then given an appointment, and the physiotherapist assesses them, and if there are any red flags found, then they are referred to the relevant professions. If no red flags are found, then the physiotherapist continues with the patient's treatment and management. A guideline for self-referral was compiled by some of the staff and sent to all the members of the staff. So, staff development and the way forward. What we would like to see in the future initiative is to provide training to enable physiotherapists to read and understand blood investigations and to provide training in pharmacology and rehabilitation. This will all assist us and enhance our skills in order to give a more holistic treatment. Our vision, maybe a bit ambitious, is to acquire the privileges to refer patients for x-rays to help differentiate with diagnosis and to introduce a physiotherapy service of diagnostic ultrasound in musculoskeletal conditions. This will ultimately enhance our skills and enable physiotherapists at primary healthcare to provide a more efficient, effective, and timely service, reducing referral pathway and healthcare costs. Thank you.
Good afternoon. As they say, we leave the best for last, and I believe that is why the organizing committee left podiatry in the last two presentations. Well, joking apart, I would like to sincerely thank everyone who for the past 40 years have believed in our profession. Our profession has developed beyond our wildest dreams. I'm really excited to be here, not as Andrew, but as representing the podiatry service. 40 years ago, we started with a small clinic. Today, we have a center of excellence. We have clinics all over the island. And honestly, I feel that we are doing our best to, as our motto says, promoting mobility. Okay? So basically, yes. This Center of Excellence in Birkirkara, and whilst I would like to point and make this clear to all, whilst we're talking about a Center of Excellence in Birkirkara, I believe, and I want you to understand, that all podiatrists, not those who only working in Birkirkara, but the podiatrists who are working in Mellieħa, who are working in Fgura, who are working in Mosta, who are working anywhere. They're all professionals. They are all doing their best so that everybody stays on his feet, everybody remains independent. Okay? And how do we do it? How do we aim to keep people mobile? How do we aim to keep people more independent? We introduce services with the help of the authorities. Obviously, if the authorities didn't believe in us, they wouldn't have given us the opportunity to have this center. So, yes, I must say again, thank you to everyone who believed in us. Our services at Birkirkara, where we have the Center of Excellence, is core podiatry. Core podiatry is from where we started 40 years ago. It was nail cutting, removing of hard skin, and some, while they do joke about this, oh, intom tal-kallijiet, it means that they don't suffer from any corns, because corns can be painful, corns can be disabling. You come to us, after 15 minutes, you go out pain-free, and that is the strength of podiatry. So we started from there. We developed a number of services. There is podopediatrics, which Ivan now will explain more in detail, gait analysis. We have a computerized gait system, but the computer alone will do nothing. We have 2 podiatrists. They're doing their PhD on gait analysis, and that is our strength. It is the stuff, together with the opportunities given to us by the authorities. Okay? Diabetes is a very important section for us. It is not just in Birkirkara where we treat diabetic patients. We treat them everywhere, in all community clinics. So I urge you, because it's a community clinic, it doesn't mean we're giving a less service. We are giving the same service. If they need more specialized services, yes, by all means, they are referred to Birkirkara. But basic services, I mean, diabetes when it comes to screening, it's done everywhere. Okay? Musculoskeletal problems. We have podiatrists working both at Mater Dei and primary health, we're trying in line with the with the department to reduce the load from Mater Dei to bring it to primary health. Okay, it's in line with the policy of the department, as Dr. Fern said in his opening speech. So basically, we are there liaising between Mater Dei and primary health and treating these patients. Wound management, the same. We have both clinics at Mater Dei and at Birkirkara now. This clinic has recently opened. In fact, we got a podiatrist from Mater Dei to help us in this. Now he is helping our staff at primary health to continue with the wound management program. Nail surgery, we do nail surgery at Birkirkara. Vascular assessment. Vascular assessment is done in all health centers and in all community clinics, not just at Birkirkara. But at Birkirkara, we have more specialized instruments to detect more difficult situations. And education. Education, one of the advantages we have when we're with patients, we can talk to patients whilst we're doing the treatment, and education is most of the time ongoing. Okay, so basically, this is what we are doing at Birkirkara. It's not just Birkirkara, I say it again and again. I never get fed up of saying this. Podiatry is not just Birkirkara. At Birkirkara, it's true, we have a center of excellence. It's true, we give specialized services. It's true, our staff there have continued their studies. They are specialized, some of them, but in other health centers, we still give a very good service. As a final note, whilst during this morning's presentation, some would say 83% of happiness, of being happy with our service is a good result. Personally, as Andrew Cicluna, as the lead of podiatry, I would ask, what about the other 17%? We need to reach out to these 17%. We need to find out why they're not happy with our service. 17% is not a small number. So I urge everyone, let us reach to these 17%, okay? Let us give them all, because it's not fair that 17% are not happy with our service. So let us all not be happy with the 83%, but look at the other 17% who are not happy. With this, I thank you all for all your support throughout these years. Thank you.
So, good afternoon. I join Andrew by thanking all the organization committee for this conference. So, Podopediatrics initiated back in 2012. The aim of this clinic is mainly, first and foremost, is to treat children from birth till the 16 years of age. Okay, but mainly it's to educate and to deal with conditions according to evidence-based literature. Okay, and also to reassure parents or guardians that some foot and ankle conditions could be part of normal child growth development. Okay, some parents or even guardians or those who take care of children are a bit overprotective, or more likely like to surf on social media and internet, and from a small thing they try to exaggerate about foot conditions and not ask the professional about these conditions. Another thing we strive to do is to work hand in hand with other healthcare professions in pediatric arena. So we expanded our clinic, even our services with other healthcare professionals, mainly physios, the school medical services, services at OPU at St. Luke's Hospital. And this is our new clinic. at Bikirkara Center of Excellence, and this is the team. So we see children all around from Malta and Gozo, okay? Together with Roxanne. Roxanne is the main podiatrist at Bikirkara Center of Excellence. I'm quite mobile. I tend to go around several clinics, so we give our service and reach many kids as possible. The important thing to start with is the definition of podopediatrics, and children are not small adults. And that's quite challenging when dealing with children, because children are changing all the time. They are growing all the time, so you need to monitor their condition and think about what would be the diagnosis and maybe what are the outcomes of your treatment. It's quite challenging because certain foot conditions which are not under the podiatry profession sometimes are quite bad to kids. So even referring to other healthcare professions, it helps us a lot, even understanding what's going on in the child. So podopediatrics, in a nutshell, encapsulates the diagnosis and management of pediatric foot disorders and their associated effects upon the lower limb and the child in general. It also involves the assessment of the lower limb and associated exoskeletal and health and disease, and the evaluation and treatment of conditions that may be isolated to the foot or manifestation of systemic disease. This also involves a specialist approach to the care of the child, separate from that involving assessment the care of the adult. The care transfers all medical and surgical specialties and take cognizance of the vagaries of child development, age, and psychosocial needs of the child and the parent. So we treat various foot conditions, from ingrowing toenails, heel pain due to growing pains like Sever's disease, biomechanical foot conditions like flat feet, hypermobilities, in towing gaits. We get many referrals, and I think those which are in the scoliosis team, due to leg length discrepancy or even over-pronated feet that are causing even problems regarding scoliosis. Overriding and overlapping toes, mostly newborns, okay, with these conditions. A plethora of dermatological conditions, mostly verruca and tinea, probably due to poor hygiene, and maybe people or kids do sports and use communal showers. Onychomycosis, yes, it's common in children as well. We do nail surgery as well in children, and cryotherapy using cryopen. Cryopen, we use it, it's like a pen. We use cartridges of nitrous oxide, but we use it as a last resort because it's a bit painful for children. We start with topical treatments, and we monitor every 3 or 4 weeks as necessary regarding verruca treatments. Today, from 2012 till this month, we saw 40,000 appointments, and this does not include the orthotic treatment. When I say orthotic treatment is when we give those children who needs insoles, all right, they are free of charge. And this is in collaboration with the OPU, Orthotics and Prosthetics Units at St. Luke's Hospital. We are also in collaboration with the Rheumatology Clinic and the Mater Dei Hospital. I do even visits at the National Sports School as well, OPU as mentioned. We get referrals from the Pediatric Physiotherapy at Mater Dei Hospital, even at CDAU, I didn't mention it here. Well Baby Clinic as well, and the school medical service team at the primary healthcare. During COVID, Ms. Camilleri approached me and told me, listen, although the clinics are closed due to the pandemic, the demand is still high. I agreed, and we had this brilliant idea that this service would go even to the primary healthcare Facebook page. So all those who needed consultation, information, or had a query, or they're worried about something, they simply send a private message to the primary healthcare Facebook page. We are a team of professionals there, so when we see the message, if it's for me, for podiatry, I reply to the client and see to their worries. And I guide them for treatment, or for an appointment, or for the query they have, and we keep our consultation or our monitoring even through the primary healthcare Facebook page. It works, and it works till today. Fortunately or unfortunately, there are no hours when these send these messages, even at 11 at night. But I think parents worry for their children. I'm a parent as well, so I don't mind even replying for a worried parent at 11 o'clock at night. So the online consultations from 24th April 2020 till 27 January, we had 747 online consultations. 30% of them were given online advice and treatment. 70% were given appointment at our clinics. Online consultations from 20th April 2020 till date spiked up to 1,200 online queries and consultations. So, to attend to our clinic, no referral needed, okay? The simpler, the better, okay? But it helps when I have a referral, so we can go back to the healthcare professional who referred the client, so we keep him posted, or keep her posted about the foot condition. The service is mainly at Biennial Center of Excellence. Urgent and information queries can be done to the primary healthcare Facebook page by sending a private message 24/7, 7 days a week. Okay, so I will reply to all the messages. We don't have Saturday appointments like other clinics who see children as well, but we have a once weekly afternoon session at Biennial Center of Excellence. The way forward, I happen to be as well the president of the Association of Podiatrists of Malta, and recently we had a meeting with Ms. Camilleri, and we agreed to move forward even in pediatrics together with association and involve other podiatrists in this adventure regarding podopediatrics in primary healthcare. And we are trying and we are working on a national foot screening for children aged 8 till 10, because we can see, we can diagnose if the children needs biomechanical treatments like insoles regarding flat feet or overpronation, which can affect even their growth and even their gait. Education activities as well in collaboration with Association of Podiatrists of Malta, and foot health education campaign through social media, through TV, through radio. The more we can reach the general public, the parents, I think the more the information will go through. Thank you.
Thank you, Mr. Mitzi, Mr. Barras, Mr. Shikluna, and Mr. Farrugia. And we can now open the panel for questions. No questions? While we thank you all for making this an interesting conference, we welcome back on stage Ms. Rosanne Camilleri, Chief Executive Officer, Primary Healthcare, for the closing speech.
I'm here again. Thank you. The stairs is always a challenge. For those who suffer from heights and vertigos, they would know exactly what I mean. For those who don't, please sympathize. I thank you for coming to join us in this 11th biennial conference. As we have heard and seen, we have done a lot in such a short time. As I said
in the beginning. We have a very ambitious program for the future. So we basically, we're not going to stop running. We have started at a very good pace. We picked up the pace, and we need to increase the pace so that we get the energy that there is, we will not lose it. So it's impressive. The presentations were impressive. There were milestones reached. The plans for the future are very promising, not just for the primary healthcare staff, which gives, I believe that, firmly believe that they give impetus and more energy inward, but also as all this happens, it will give an opportunity also for the public, and very good benefit for the public, that they will be benefiting from all this good and forward-looking initiatives in the very, very near future. But, I will not take very long. Again, I thank you for being here. I will take just a few minutes so that we will something small prepared for the committee that were here, that have done all these preparations, and we have cooked up something small for them so that we will show them our appreciation. So if you'll allow me, we'll call the... That's what I was saying.
Yeah. So we'll be calling Maria, the Assistant Director in Alfred Farrugia, the Financial Controller, to come join us on stage.
It's Will Cole.
Sorry.
This is not what I was talking about, actually. This was something else. Oh, sweet. Oh, thank you so much. Oh. Thank you. Thank you. They somehow know that roses, I love roses, but thank you very much. Thank you. I run after these people all the time. I bug them. All the time at all odd hours of the week and weekend. So one can appreciate that we couldn't have done all this without the dedication and the inputting of a lot of times. This is not an 8-hour job. This is a 24-hour, 7 days a week, basically. We're there, we're accessible. And thank you. Thank you again. That too. Thank you so much. Thank you. Thank you so very much. It's beautiful. Thank you. Thank you so much. I appreciate it a lot. So we could call we take photos also. Thank you. We call the management team, the steering committee. That's I have. Well, this is, as you can see, this is not rehearsed. We call the committee members because we have something that we would like to show appreciation with. Small token. I don't have the list. Dorothy Shikluna.
Josette Superas.
Adrian Potch.
Come up, please.
Maria Briffa.
Dominika Tsafaidi.
Alfred Farrugia.
I'll open them here one by.
I'd like to present the committee that has worked so hard
Josette
for this.
Shikluna.
Josette.
Dominika Tsafardi.
Maria. Just one by one. Obviously, you can pass them. Yeah, Dorothy's. Maria's. Okay. Sorry.
We'd also like to call the speakers because we have something for them. We can, like we did last time during the break, have something as a token for their participation and their patience in preparing their presentations. Yes. Yes. Yeah. Okay. We have more. No,
Daniel.
Andreana, this is fine.
Oh.
Thank
you.
you so much.
Thank you. Adrian.
Yes. Well, Daniela, please get whatever it is that we need to get. We need them. Yeah. Dominic, here. Here you go. Take that, Daniel. The syringe. Alfred. We need the kids.
We need Deborah Spears on stage. Deborah. We need Deborah.
Deborah. Deborah. Here you are. This you keep and then you swap it. Deborah is coming. Josette, we lost your flower. There you are. Thank you very much. Thank you. Who's this? I have Adrian. Where is Adrian? Who's this? Because they're in green, so we have an Adrian and Andreana.
Thank you. Thank you.
Yes?
Yes.
Okay, thank you. Thank you. There you have something else. Maria. It's a little bit. I've prepared a surprise, and it's not functioning properly. It's like all surprises. Sometimes the people don't like surprises, and that is why. I've prepared a surprise, which is Christmas comes early, a bit early, and it's at the back, and it's taking time to come from the back to the stage. Please get them, because people are hungry here.
Need insieme ċatti għu Le, biex għaxed nħontu għu kalbi. Le, ovvja, għan insejn.
here, she came here. It's easier. Got you a small gift for Christmas, one each. And I'd like to call as well Dr. Ray Samout, who's the clinical chair for the primary healthcare, and Miss Isabella Aquilina, who's the director of nursing services. I've done a lot of talking without these two people beside me. I wouldn't have also managed to achieve what we've achieved today, and I thank them. Ray, we start with you. Thank you very much.
I'd like to thank everybody, first of all, for these 2 years, for helping me going through the COVID, which was quite frustrating for us, but we managed it, and I think in the future we have better to manage it with it. Thank you.
Thank you. Thank you.
Thank you. Thank you, Ms. Camilleri. On behalf of the nursing administration as well, primarily I wish to thank to Ms. Camilleri for being instrumental and by supporting us in all our ventures. And I would like to thank you all primarily as well and for coming here and attending here, but most of all for your dedication and passion towards our patient. Thank you to all.
Now we have a cake for all. They're here. Thank you very much. Christmas comes early. I told you it's a Christmas cake. Something's very small, but I'm sure they will enjoy it as well. Diabetes people, take note, please. Diabetes and whatever else doesn't happen in Christmas time, so we'll enjoy it. Then we'll talk about Ilona and Flair later. Thank you, Adrian. Just like an assembly. Thank you very much for everything.
No more speakers.
Wait.
Flair and Ilona will do their magic after Christmas.
Thank you.
Thank you. I'll just leave them here.
That's for you. You can keep it.
Thank you.
Yeah, I know. And we have one for Andreana, but
Yes,
she's
yes,
going,
yes,
she's busy holding the tablet.
Now we can call on stage Miss Marika Podakoner, Marcon Grima, Mr. Carmer Koldina,
yes, we need them.
for the tokens.
انزلوا من هناك هيطلعوا من الناحية الأخرى. We're going downstairs. I share a photographer. Nice.
Okay. Miss Alexandra Tsopardi. Dr. Renzo Pacheasha, Mr. Ronald Barbara, Dr. Adrian Attar-Trevisan, and Ms. Lina Sultana. Mr. Rosario Mitzi, Ms. Jacqueline Shiberras, Mr. Andrew Shikluna, and Mr. Ivan Farrugia. While we once again thank you for your attendance and participation, we urge you to please remain seated until you are called by the ushers who will be leading you to the dining hall. It is important to please keep the same table number during lunch. Thank you and bon appetit.